Welcome to the Deep Dive. Today we're tackling a really critical topic, acute renovascular disease.
Yeah, serious stuff.
We're going to unpack what happens when the kidneys suddenly, lose their blood supply, both arteries in and veins out.
Right.
And our mission today, pretty straightforward, distill the vital info on how to best save kidney function when this happens. It's urgent.
Exactly. And for this deep dive, we're drawing heavily from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
The big one.
It's pretty much the definitive guide. It gives a really detailed look at the complexities we'll be digging into.
And time is just absolutely critical here, isn't it? This isn't something that can wait.
Not at all.
Rapid diagnosis, swift treatment, they're paramount. Because if the kidneys are starved of blood, that permanent damage, it can happen incredibly fast.
Yeah, the textbook really hammers that home. The duration and, the severity of that blood flow reduction, those are the absolute key factors.
Okay. So what are the main ways this happens? What are we looking at?
Well, there are a few main culprits we'll explore. You've got renal artery thrombosis. That's a clot forming right there in the kidney's artery.
Okay.
Then embolism, a clot travels from somewhere else, gets stuck.
Right.
Trauma, obviously, can injure the vessels directly. Aortic or renal artery dissection, a tear in the artery wall.
Nasty.
Yeah. And also iatrogenic injury, that's damage from medical procedures, unfortunately. And finally, we'll cover renal vein thrombosis, blockage on the vein side.
And it's worth pointing out, like the source material says, a lot of the evidence for managing this stuff comes from case reports, smaller studies.
That's a really important point, yeah. There aren't always huge randomized trials telling us exactly what to do.
So it really highlights how complex these situations are and, the need for good clinical judgment.
Absolutely.
Okay, let's unpack the immediate impact. What happens right when that blood flow drops?
Right. So down at the cellular level, it sets off this damaging chain reaction.
Yeah.
The glomeruli, the kidney's little filters, they can collapse. And the tubules, which reabsorb stuff, they undergo necrosis, cell death, basically.
So everything just starts shutting down.
Pretty much leads to a rapid drop in filtering ability, loss of function. It's bad news quickly.
And what's really fascinating, or maybe scary, is that restoring the blood flow doesn't just fix everything instantly, right?
Yeah.
There's this other issue.
Yeah, exactly. It's called reperfusion injury. It sounds backward, but reintroducing blood can actually cause more damage.
How does that work?
Well, the initial lack of oxygen, the ischemia, it triggers inflammation. You get cytokines released, white blood cells rush in. And on top of that, the body starts producing these harmful molecules, things like nitric oxide, reactive oxygen species, which can further damage the tissue and mess up blood flow regulation within the kidney itself.
Wow. So it's like a double whammy. Damage from no blood, then more damage when it comes back.
Pretty much. It really shows how sensitive the kidneys are to these sudden changes.
And you mentioned duration earlier. The sources are really clear on how critical the time factor is.
Oh, absolutely critical. For a normal kidney, even just 1 hour of what we call warm ischemia, no blood flow at body temp, that can cause a huge function loss, like 70–80%.
70 to 80% in just an hour.
Yeah. Now, the good news is, at that point, full recovery is often still possible. It might take weeks, but it can happen.
But that window closes fast, doesn't it?
It does. If that warm ischemia goes beyond 2 hours, the chance of long-term recovery drops significantly, maybe down to like 30–50% of baseline function.
Okay, so 2 hours is a major threshold.
Seems to be. And unfortunately, the point of no return isn't much further out. Animal models suggest irreversible damage might happen after just 3 to 4 hours of complete warm ischemia.
3 to 4 hours.
So, there's some variability there. And if you look at human kidney transplants, if there's prolonged warm ischemia, say, over 45 minutes, the graft often doesn't work well early on.
Right.
And some research suggests that beyond 90 minutes of acute warm ischemia, the kidney's chance of really bouncing back functionally starts to plummet.
That is a sobering timeline. And it really hits home clinically, right? Like, even if you manage to reopen the artery after, say, 6 hours.
Exactly. You might have technical success, the vessel's open, but the kidney itself might already be too far gone, especially if the patient's already in kidney failure, not making urine. Functional recovery might just not happen.
A tough reality.
Now, it's important to contrast that the sudden acute blockage with situations where the narrowing happens slowly. Gradually.
Right, like chronic stenosis building up over time.
Precisely, because the body can sometimes adapt. It's pretty remarkable, actually.
How so? What happens?
Well, if a main renal artery narrows slowly over months or years, it can trigger the growth of collateral blood vessels.
Like natural bypasses?
Kind of, yeah. Backup routes, they can sprout from nearby arteries, inferior adrenals, gonadal, ureteral, internal iliac, lumbar, intercostal, capsular arteries, sometimes even the inferior mesenteric.
Wow, quite a network.
It can be. And what's really fascinating, the sources say up to 80% of the kidney's blood supply through these collaterals might become independent of the main renal artery.
80%. So even if the main pipe gets completely blocked.
These collaterals could potentially keep the kidney alive and functioning, at least to some degree.
That's incredible. And you also have accessory renal arteries, right? People born with extras.
Yeah, that's another factor. They branch right off the aorta, and they're surprisingly common. Maybe 24% to 42% of people have them.
Ah.
So those can obviously keep supplying blood even if the main one is blocked.
So with a slow, gradual occlusion, the kidney might limp along.
Sort of. Filtration might be reduced, but some tubular function can often be preserved. Animal studies show kidneys can survive with collateral development over weeks.
And does this happen to people too?
Yeah, there are reports of functional recovery even after the main artery's been blocked for more than 24 hours. It really highlights how crucial those collaterals can be.
So how would you know if collaterals are working?
A key clue on ultrasound, if you see good blood flow in the renal vein, even though the main artery looks blocked, that's a strong sign that collateral arteries are doing the job.
Interesting. Okay, so that covers the arterial side.
Yeah,
But you mentioned ischemia can also come from the veins, renal vein thrombosis.
that's right. A blood clot in the renal vein, the one draining the kidney, can also cause acute ischemia, either just in the renal vein or maybe extending from clots in the bigger inferior vena cava.
And is the impact similar? Time dependent.
Yes, very similar principles apply. How fast the vein blocks and whether there's collateral venous drainage, those are the key determinants of damage.
So if it blocks fast with no backups.
You get major congestion, the kidney swells up edema, that stretches the outer capsule, causing pain. And in severe cases, you can even get hemorrhagic infarction bleeding into the kidney tissue.
Ouch.
And interestingly, some experimental models suggest venous blockage might actually be more damaging than arterial blockage.
Really? More damaging.
Potentially, yeah.
Yeah.
Shows how vital that unobstructed outflow is for the kidney.
Okay, so we understand the how and the what happens. Let's shift to recognizing it.
Yeah.
How do these problems actually present? What symptoms should make you suspicious?
Well, here's the tricky part. The symptoms are often really nonspecific.
Ah, not straightforward then.
Not usually. Patients might have abdominal pain, back pain, maybe flank pain, shortness of breath, nausea, vomiting.
Kind of generic stuff.
Exactly. Blood in the urine, maybe,
Yeah.
decreased urine output, or none at all. Sometimes a sudden jump in blood pressure. But none of these scream kidney artery blockage.
Yeah, that sounds like it could be a lot of things.
It really could. The list of other possibilities is huge. Kidney stones, kidney infections, pyelonephritis,
Okay.
but also stuff completely outside the kidney, mesenteric ischemia, gallbladder problems, gastritis, spleen issues, even a heart attack or a pulmonary embolism. They can all present similarly sometimes.
So diagnosis must be tough,
It can be very challenging, and this overlap is a big reason why diagnosis often gets delayed.
which, as we said, is bad news for the kidney.
Terribly bad news. The sources stress that patients often don't show up for hours, even days after symptoms start.
Oh, wow.
Yeah, studies show for embolic blockages linked to AFib, presentation is often over 24 hours later. For acute renal infarction generally, the median time was over 30 hours in one study.
That's well past that critical 2-3 hour window we talked about.
Way past it. Really reduces the chances of successful revascularization saving the kidney.
And what about renal vein occlusion specifically? Any different signs?
Maybe some unilateral flank tenderness, signs of congestion, but feeling an enlarged kidney in adults, that's actually rare.
Okay.
And in newborns, it's even trickier. That classic triad flank mass, blood in urine, low platelets only shows up in maybe 13% of cases. Often it's much more subtle.
Okay, so symptoms are tricky, often delayed. How did doctors figure it out then? What's the diagnostic workup?
Well, lab tests can give some clues, but again, nothing is definitive on its own for acute ischemia.
No magic blood test then.
Nope. You look at the whole picture, maybe a high white blood cell count, elevated LDH, lactate dehydrogenase, blood or protein in the urine. An elevated D-dimer can suggest clotting. Sometimes eosinophilia, which might point towards cholesterol crystal embolism, that CCE type we mentioned.
Right.
But here's a really crucial point from the textbook. Creatinine, the standard kidney function marker. It can be normal in up to half of these cases.
Half. Wow. So a normal creatinine doesn't rule it out at all.
Not even close. And sometimes, asymptomatic unilateral ischemia just gets picked up by chance on imaging done for something else entirely.
So imaging becomes really, really important then.
Absolutely critical because the clinical picture and labs are often so murky. Ideally, you want an imaging test that's fast, available, non-invasive, cheap, no radiation, no contrast.
Unicorn test.
Exactly. Doesn't exist. So you weigh the pros and cons of what you do have.
Okay, so what are the main options? Let's start with CT angiography, CTA.
Right. CTA is often the go-to. It's widely available, pretty fast. Good for ruling out other things too. Sensitivity for acute renal ischemia is decent, around 80%, which is better than ultrasound. Plus, it shows the aorta and iliac arteries well, which helps if you're planning a procedure.
And for vein clots?
For renal vein thrombosis, CTA, especially with non-contrast and venous phase images, is basically the gold standard, near 100% accuracy.
Okay. What does an infarct actually look like on CTA?
Typically, you see a wedge-shaped, low-density area, maybe some kidney swelling. Sometimes you see what's called a cortical rim sign.
Cortical rim sign.
Yeah, that means the very outer layer, the cortex, is still getting some blood, maybe from tiny capsular collateral vessels, while the inner part is infarcted, dead. It looks like a rim of functioning tissue.
Interesting. Okay, what about MRA? Magnetic resonance angiography.
MRA can look at anatomy and physiology, like blood flow. For general renal artery disease, non-contrast MRA is considered about as reliable as CTA.
Any advantages?
Well, it might be better for seeing really small arteries and the kidney tissue itself. And it's super useful if the patient can't have contrast dye, like with severe kidney disease already present. It's used more and more for chronic kidney issues.
But for acute ischemia?
It's often not the first choice. It's generally slower than CTA, needs more image processing, maybe not as readily available 24/7.
I see.
Though MRI or MRA can be really helpful if there's suspicion of kidney cancer involved with a renal vein thrombosis.
Got it. What about good old ultrasound? No radiation, no contrast.
Big advantages for sure, but the downside is it's generally less sensitive than CTA for picking up ischemia. If you do see an infarct, it looks like a wedge-shaped low echo area, and Doppler shows no blood flow there, but it's very operator dependent.
It depends on the tech skill.
Yeah, and it can be tough in obese patients, or if there's lots of bowel gas obscuring the view. Some studies show pretty low detection rates for renal embolism with ultrasound alone. Color Doppler is better for big infarcts from a main artery blockage, but you usually need other imaging for smaller ones. Sometimes a low flow velocity in the artery might hint at a clot further down. And for vein thrombosis, it can show kidney swelling.
Okay. Then there's the nuclear renal scan. The source said that might be the most sensitive.
Yeah, reported sensitivity around 97%, which sounds amazing.
97. Why isn't that used all the time then?
Practicalities, mostly. They tend to be time-consuming, less available on an emergency basis compared to CT or ultrasound.
I see. What does it show if it is positive?
The classic finding is a big drop in blood flow to the kidney, but the kidney size looks pretty normal, shows the perfusion defect clearly.
Okay. And lastly, angiography. The one with the catheter.
Right. Direct angiography, sticking a catheter in. Its main role now in acute ischemia is usually right before or doing endovascular treatment.
Like clot removal or stenting.
Exactly. Or maybe if other imaging is inconclusive, but you have a really high suspicion, maybe for an iatrogenic injury during a prior procedure.
Makes sense. Okay, so that's diagnosis. Let's dive into the specific causes and treatments. Number one cause you mentioned, renal artery embolism. Clot travels.
Yep, most common cause of acute renal ischemia overall. A clot, usually from the heart or aorta, breaks off, travels downstream, and gets stuck in a renal artery.
Who's at risk for that?
Lots of risk factors. Atrial fibrillation is a big one. Heart disease ischemic, cardiomyopathy, valve problems, history of blood clots anywhere, cardiac tumors even, plaque in the aorta. Rarely a paradoxical embolism through a hole in the heart.
So mostly heart or aorta issues.
Primarily. But despite all that, it's still relatively rare overall in hospitalized patients, maybe 0.007% or so.
And do these clots usually block the main artery or smaller ones?
The sources say they more often block the branches, segmental arteries, which can make it hard sometimes to tell if it's an embolus or a local thrombus unless you clearly find the source, like a clot in the heart.
Okay. And you mentioned cholesterol crystal embolism, CCE, earlier. That's different.
Yeah, CCE is distinct. It's tiny little bits of cholesterol debris showering off plaques, usually in the aorta, risk factors. Male, high blood pressure, atherosclerosis. And crucially, it can happen after procedures involving catheters in the aorta.
And the outcome is worse.
Yeah, CCE has a pretty high risk of progression to needing dialysis and higher mortality. Nasty stuff.
So for any kind of embolism, what's the first step?
Immediate anticoagulation. Usually heparin infusion. You have to stop more clots forming or traveling.
Makes sense. Prevent further damage.
Absolutely. But then the next crucial step is finding that source. Where did the clot come from?
Right, because it could happen again.
Exactly. You need to treat the underlying problem, fix an aneurysm, remove a clot from the heart, close a PFO, replace a valve, whatever it is, because recurrence is a real risk. Over 20% of patients with a renal embolus have had clots before.
Okay, so anticoagulation first, then find and treat the source. What about getting the clot out of the kidney artery? Revascularization.
It's considered. Definitely, especially if both kidneys are hit or if it's a solitary kidney and there seems to be salvageable function. But anticoagulation alone can sometimes be enough, especially for a unilateral embolism if the kidney wasn't great to begin with or the potential for recovery seems low.
So it's a judgment call.
Very much so. Many patients in studies were managed just with anticoagulation, and outcomes were often reasonable kidney function preserved or recovered, low dialysis rates, but you have to weigh the risks and benefits.
Okay. If you do decide to intervene, what are the options? Endovascular.
Yeah, endovascular is usually the first line now. Catheter-directed thrombolysis-stripping clot-busting drugs right onto the clot can work well, especially for clots in the main branches or smaller arteries.
Just dissolve it away.
Sometimes. But often combining it with mechanical thrombectomy using a device to suck out or break up the clot is more definitive, gets it done in one go.
That makes sense.
You can also use aspiration devices, balloon angioplasty, maybe stenting, often in combination. But the sources suggest thrombolysis for a complete blockage of the main renal artery might not yield great functional results. Kidney might already be too far gone.
Okay. What about open surgery? Cutting it out.
Surgical embolectomy. Much less common now for embolism. It's more invasive, takes longer.
Right.
Usually reserved for when endovascular fails or just isn't feasible. It involves an incision, finding the artery, opening it, pulling the clot out, check with ultrasound if it's all gone.
Sounds like a bigger deal.
It is. Older studies had pretty high mortality rates, like 25%. So with good endovascular options, surgery for embolism is pretty rare today.
Okay, that's embolism.
What?
What about the next cause? Renal artery thrombosis. Clot forming locally.
Right. This happens because of some underlying problem in the renal artery or nearby vessels.
Like what?
Most common is probably atherosclerosis plaque buildup causing narrowing. Then a clot forms on top of that, usually in people over 55.
So stenosis leads to thrombosis.
It can, yeah. Though just having stenosis doesn't automatically mean it'll thrombose. It's actually relatively rare for stable stenosis to suddenly clot off completely without some other trigger, like dehydration or low blood pressure.
Ah, okay.
The risk of thrombosis over 5 years with known stenosis is generally low, but it's higher if someone has high blood pressure, diabetes, or really severe stenosis, like over 60%.
What else causes local thrombosis besides atherosclerosis?
Aortic aneurysms, aortic or renal artery dissections, fibromuscular dysplasia, FMD, arteritis, a clot forming in a previous stent.
Thrombosis, right?
Yeah. Also hypercoagulable states, conditions making blood clot too easily, and trauma, including iatrogenic trauma from procedures. Less common things too, like antiphospholipid syndrome, factor V Leiden, HIT, Behçet's disease. Lots of possibilities.
Let's touch on dissection again. Spontaneous renal artery dissection.
Yeah, that's sudden tear in the artery wall. More common in men, about 4 to 1. It's actually the second most common cause of acute renal ischemia in some series.
And the key sign on imaging is that flap.
Exactly, the intimal flap. Can be one kidney or both. Risk factors include FMD, Ehlers-Danlos syndrome, cocaine use, really strenuous exercise, and iatrogenic causes like after angiography or even lithotripsy.
Okay, so for thrombosis from any of these causes, what's the management? Still anticoagulation.
Absolutely crucial, yes. Systemic anticoagulation is needed regardless of whether you do revascularization. It stops the clot spreading, helps keep collaterals open, plus tight blood pressure control managing fluids.
And what about trying to open the artery itself? Endovascular options again.
Yeah, similar toolkit. Angioplasty and stenting are key for underlying stenosis or in-stent thrombosis. Thrombolysis, often with mechanical thrombectomy or aspiration, can work, especially for clots further down. Sometimes you need a combination.
And for dissection, can you stent that?
Yes, stenting can effectively tack down that intimal flap and restore flow. Studies show pretty good technical success and improvement in kidney function and blood pressure for dissection treated endovascularly.
Any special tools used there?
Intravascular ultrasound, IVUS, can be really helpful with dissections. It's a tiny ultrasound probe on a catheter, goes inside the artery.
Ah, to see inside.
Exactly. Helps confirm it as a dissection, and crucially, helps you figure out the true lumen versus the false lumen so you can place the stent correctly.
Smart. Okay, what about open surgery for thrombosis?
Again, more invasive, more ischemic time for the kidney, so it's usually reserved for specific cases.
Like when?
Maybe if the ischemia time is short, kidney function was good before, there are good collaterals. Or if endovascular failed or isn't possible, maybe for extensive clots where endo just won't cut it.
And what do they do surgically?
Could be thrombectomy, removing the clot, bypass surgery around the blockage, or endarterectomy, cleaning out plaque. Exposure is similar to embolectomy.
Outcomes.
Surgical mortality is still significant, maybe 15–25%, but kidney salvage happens in about 65% of cases when it's attempted appropriately. It might be preferred if thrombolysis is absolutely contraindicated. There are reports of successful surgical thrombectomy for HIT-related thrombosis, too.
And for spontaneous dissection. Is surgery common?
Evidence is limited, mostly from elective surgeries for hypertension caused by dissection, not acute ischemia. Some dissections, especially if they only cause a small infarct, can actually heal okay with just medical management, blood pressure meds, and anticoagulation.
Okay, let's move to trauma. Renovascular trauma. Injury to the vessels.
Right. Relatively rare in blunt abdominal trauma, less than 1%. But when it happens, it's often alongside other injuries, kidney itself, liver, spleen.
Makes sense. Multi-trauma.
Yeah, and sometimes other vessel injuries too, like the renal vein or IVC. The mechanism is often rapid deceleration, car crash, or direct compression. Leads to tears, dissections, thrombosis, can injure the collecting system too.
How is treatment approached? Always try to fix the vessel.
It's selective revascularization. You weigh things carefully. More likely to try if both kidneys are injured or it's a single functioning kidney.
Because the consequences of losing function are dire?
Exactly. An advantage in trauma sometimes is you might have a better idea of when the injury occurred, the ischemia time.
Compared to a spontaneous clot.
Right. Helps decision-making. Factors against revascularization include really severe injury at the hilum, extensive kidney damage overall, or if the other kidney is fine, but the patient is unstable with many other injuries.
And that time limit still applies.
Generally, yes. Warm ischemia over 2–3 hours. Low chance of salvage. And you absolutely need to check for other injuries before considering anticoagulation during a procedure.
So what are the management options besides revascularization?
Nephrectomy, removing the kidney, embolization, blocking off bleeding vessels intentionally, or just observation, maybe with anticoagulation if safe. Some complex injuries can heal without vessel repair.
What techniques are used for revascularization in trauma?
Endovascular stenting is common now. But if the artery is completely blocked, stenting often fails technically. Embolization can be a backup then to stop bleeding.
How do outcomes look overall?
Many blunt injuries end up being managed non-operatively based on large databases. Some need immediate nephrectomy or surgery stenting. Overall mortality can be high, like 21% in one study, but often due to the associated injuries.
Right, the multi-trauma aspect.
Yeah, mortality is lower if it's just an isolated renal artery injury, but revascularization or nephrectomy often mean longer hospital stays, which led some to suggest reserving intervention mainly for bilateral or solitary kidney injuries to avoid long-term dialysis.
Makes sense. Kidney salvage rates aren't always great.
In unilateral trauma, salvage rates can be low, maybe around 25%. Injury severity scores predict outcomes. Interestingly, arterial repairs might do worse than venous repairs in trauma, and even endovascular treatment can have complications, sometimes still needing later embolization or nephrectomy.
Complex stuff. Okay, last major cause, renal vein thrombosis, clot in the vein.
Yep. Rare in adults, less than 1 per million per year, but it's the most common non-catheter thrombosis in newborns.
Who gets it as an adult?
Risk factors include cancer, especially kidney cancer, lymphoma, retroperitoneal tumors. Nephrotic syndrome is a big one. Inherited clotting disorders. Local surgery or inflammation. Oral contraceptives, pregnancy, infection.
So malignancy and nephrotic syndrome are common drivers in adults.
Often, yes. Average age is mid-50s, slightly more common in men. Can also be iatrogenic, from IVC filters or central lines.
And in babies.
Mostly in the first month. Risk factors, there are central lines, dehydration, hypercoagulable states, prolonged low blood pressure.
What's the main treatment for RVT?
Anticoagulation, again, it's the cornerstone for most patients. Start with heparin. Goal is to preserve kidney function, prevent clot extension, prevent PE.
How long do they need anticoagulation?
Depends on the cause. Temporary risk factor, maybe 3-6 months. Idiopathic or ongoing risks like cancer or an inherited disorder, often lifelong.
Does it come back often?
Yeah.
How's survival?
Recurrence rate is actually low, about 1% per patient year. But survival is generally worse than for leg DVT. Mortality can be higher in the first 6 months, especially with cancer or infection. Warfarin seems to improve survival.
And for newborns, same approach.
Anticoagulation is key. Studies show better long-term kidney function in babies treated with heparin versus no anticoagulation. Surgery or dialysis are rarely needed for kidney salvage in newborns with RVT.
When would you consider more aggressive treatment like thrombectomy or thrombolysis for RVT?
Reserved for specific acute situations, like if anticoagulation fails, the clot spreads, or they get a PE. Bilateral RVT or RVT in a single kidney. Big clots in the IVC too. Acute kidney failure caused by the RVT, or really persistent, severe flank pain despite anticoagulation.
And surgery, thrombectomy.
Considered if anticoagulation is contraindicated, if thrombolysis fails, or maybe if they're already planning a nephrectomy for cancer anyway. But nephrectomy itself for just RVT, very limited role, maybe only for severe bleeding after infarction.
Okay, that covers a lot of ground. Let's try to recap the key takeaways from this deep dive.
Right. I think number one is the time sensitivity of acute renovascular ischemia. Every minute counts.
Absolutely. And the importance of figuring out if it's arterial or venous,
Yeah.
because that guides things.
Yeah, and understanding the role of collateral circulation, how it can sometimes be protective, especially in slower processes.
And we saw a whole range of diagnostic tools and treatment approaches, right? Very dependent on the specific cause and the patient.
Definitely not a one-size-fits-all situation. Management requires really careful thought about the cause, the patient's overall health, comorbidities, and crucially, that timing. How long has the kidney been ischemic?
Yeah, it's clearly complex, demands careful, nuanced decision-making at every step.
Absolutely.
So here's a final thought for you, our listener, to ponder. We're seeing rapid advances in endovascular techniques, right? Minimally invasive stuff.
Constantly evolving.
So what might the future hold? Could these advances lead to even faster, more effective ways to restore blood flow in these critical situations? And maybe thinking longer term. We know the immediate threats, but what questions still linger about the long-term health and resilience of a kidney after it's survived one of these ischemic hits?
Good questions. There's still a lot to learn about optimizing long-term outcomes after these events. It's definitely a dynamic field.
It really is. Understanding these fundamentals we discussed today is key to appreciating that ongoing progress. Thanks for taking this deep dive with us.